Hi everyone, Scott Nicholson with the Judi Nicholson Kidney Cancer Foundation. Today I'm here for our fourth Patient Support Speaker Series, and joining me today, a very exciting speaker, we have Dr. Winston Tan, who's from the Oncology Department at the Mayo Clinic here in Jacksonville, Florida. He's here to answer questions for you about why patients need an oncologist, different treatment options that are available for you, and more, as well as any questions that you may have that come up during the Q&A session. So without any further ado, I would like to turn this camera around and introduce Dr. Winston Tan. Doctor, thank you for being with us today.
Thank you, Scott, for inviting me.
So, why does a patient need an oncologist?
A patient needs an oncologist because the oncologist can help them sort through the many options that they have for kidney cancer. And they can be their advocate, they can be their advisor, and many times they can basically inspire them and help them during the process.
So they will talk with them about different treatments that are for the localized disease?
No, mainly the oncologist is mainly the physician who will help them sort through the different options for metastatic disease. For localized disease, it's mainly the urologist. However, the oncologist has full knowledge of how to manage them, but the urologist would be the main person who will take care of the kidney, remove the kidney, and do the surgery.
I see. So what are the different treatments for localized disease?
So for localized disease, the standard treatment is radical nephrectomy, which is removal of the kidney. This means that the kidney is localized and it's between 12 to 14 centimeters or even smaller. The smaller the kidney mass, the better. We can even resect that mass even if it's in the blood vessel, meaning renal veins. Although there's a lot of risks with that surgery, but that's still doable by the urologist. So localized disease options would be radical nephrectomy. In this day and age, we can decrease the blood loss by doing what we call laparoscopic surgery. Laparoscopic nephrectomy is done through 3 holes, and you basically, with those small holes, avoid a lot of complications, improve recovery, and also have decreased blood loss. With that kind of surgery where there are only 3 holes, they have 3 scopes where they try to, or 2 scopes that they try to basically remove the kidney that way. There's partial nephrectomy. Partial nephrectomy is removal of the only part of the kidney instead of the whole kidney, which is done, which is the standard surgery, is radical nephrectomy. So with that, you can preserve the kidney function potentially and decrease blood loss again, hopefully, with partial nephrectomy. Mainly that option is for localized disease in certain parts of the kidney where blood vessels and other organs are not compromised. And that's a decision that the urologist will make after looking at the scans before the surgery.
I see. When should a patient consider clinical trials?
Clinical trials should be always an option for a patient where the treatment options are not clear or there are novel targets that are being used or being studied for a clinical trial. So it doesn't hurt, even though there's a standard option for your kidney cancer, to ask your physician if there are clinical trials available. That's how many of the drugs that are targeted towards blood vessels and kidney cancer, and also immune modifying drugs that have been approved in kidney cancer, they were studied in clinical trials.
A couple of questions just came
Sure.
in. Um, is there any new research or any new cures that people are talking about in terms of renal cell carcinoma?
So cure is always something that is very frequent in localized disease. In metastatic disease, that's a little more challenging because a lot of the disease has spread to different organs. So immunotherapy potentially has the chance of curing that. The classic drug would be interleukin-2, which we know would cure about 6 to 7% of people, but you have to be very healthy. The new immunotherapies, such as the PD-1 or PD-L1 inhibitors, are potentially a cure, but we do not know yet. The long-term follow-up has to be done, and now we're actually combining those immunotherapy together. So we hope that we can find some cure for a small subset of patients.
And are there any early detection signs that people can look out for? Is there anything that they can keep an eye on, or how does someone find it themselves? Like, how do they? Yeah.
Understand your question. It's very hard to find kidney cancer by yourself, but if you have symptoms like blood in the urine, microscopic blood in the urine, pain, usually those are late symptoms, flank pain, or palpable renal mass, which is only found in 10% of all kidney cancers. Fortunately, nowadays, people who have non-specific abdominal pains have a CAT scan done, and incidentally, they find kidney cancer. I'm not advocating routine CAT scan to screen for kidney cancer, but if there's a kidney mass on a routine CAT scan that's done, I think those need to be evaluated by a urologist.
I see. What are some of the options available for metastatic disease?
So I group the treatment options in 3 general groups.
Actually, I'm sorry
Sure,
to interrupt.
no
but
problem,
before
Scott.
we go on, for laymen like me, what is the difference between a localized disease and metastatic disease?
Localized disease means it's confined to the kidney. It has not spread outside the confines of the kidney.
I see.
So the kidney has blood vessels. The kidney has a capsule known as the Gerota fascia. Anything that's localized in that and have spread only to the veins but not other parts of the body, that is localized disease. If it has spread to the bones, to the lymph nodes, to the lungs, to the brain, those are what we call metastatic disease.
I see. Gotcha. Thank you for explaining that.
You're welcome.
So what are some of the options then for metastatic disease?
So there's so many drugs now approved for metastatic kidney cancer, and there are 3 categories where drugs are in general group. One is what we call vascular endothelial growth factor inhibitor. Blood vessel is important for growth of cancer. If there's a blood vessel, it feeds the cancer, makes the cancer grow. So that's vascular endothelial growth factor. So drugs like pazopanib, sunitinib are examples of that. And axitinib is another drug that's involved. So the details of those drugs should be discussed with an oncologist. The other group is immunotherapy. Immunotherapy would include interleukin-2 and PD-1 inhibitors and also PD-L1 inhibitors. So let me explain a little bit about that. The immune system is messed up in kidney cancer, and with the drugs that are available right now, we actually enhance the ability of the immune system to work. There's danger with that. However, by enhancing the immune system, we're able to control the cancer and make the patient live longer. That's the second category of drugs. The other category is what we call mTOR inhibitors. mTOR inhibitors are basically drugs that target a specific factor that enhances the growth of the kidney cancer when it spreads. And there are several of them, temsirolimus and everolimus. And actually there's another drug, a fourth category, which is a MET inhibitor. That's again an escape pathway for the cancer. So cancer grows despite drugs that are targeted towards certain molecules. There's what we call MET inhibitors, MET inhibitors. And cabozantinib is another drug that's been approved by the FDA for that indication.
I see. How do genetics play into renal cell carcinoma?
Genetics is very important. We have actually a disease that's specific for clear cell renal cancer. It's known as von Hippel-Lindau gene, which is in chromosome 3. If you have the hereditary type of this disease, you can have the kidney cancer, the eye tumors, and what we call hemangioblastoma of the brain. So these are patients who have basically the hereditary type of the renal cancer where there's mutation of the von Hippel-Lindau gene, in short VHL. In patients with sporadic clear cell renal cancer, actually they have the mutation of the gene, but they don't manifest with the other cancers that I mentioned. They only have renal cancer. 70% of kidney cancer or clear cell kidney cancer would have a mutation of the sporadic mutation of the von Hippel-Lindau gene. There are many mutations. Small other subsets of kidney cancers have mutations in chromosome 3 and other types. So that's beyond the scope of our discussion today.
How can people prevent cancer, their kidney cancer? What can they do to better keep themselves from ever getting it in the first place?
The most important thing, I think, are things that are known. So things that are known to increase the risk of kidney cancer would be smoking. I think one of the best strategic ways to prevent yourself from having cancer, including kidney cancer, would be not to smoke. Staying on a healthy diet, losing weight, treating your hypertension, controlling hypertension. Obesity can be a risk factor also for kidney cancer.
Is it true, or is there at least some evidence that processed foods in particular are to blame for the rise in cancer in society today?
It is. There's an increased incidence of that, however, not specifically for kidney cancer.
I see.
At least direct evidence.
Looks like we have one more question here. So what role does the Judi Nicholson Kidney Cancer Foundation play in this?
The Judi Nicholson Foundation is your advocate. Judi Nicholson Foundation is your partner in your care with you as a patient, with your caregiver, and of course with your physician. Very important to mention that the Judi Nicholson Foundation did a study with clear consent from the patients that they're able to share patient to patient their experiences as far as side effects of the drug. Meaning if they're taking pazopanib or Votrient, they can call an 800 number or a number at the Judi Nicholson Foundation, and a patient who actually volunteered to be a patient advocate will help that patient and tell them about their experience with the drug. Although that is only one way of helping the patient, Judi Nicholson is doing many other things, including supporting research, including organizing a conference, actually September 9, 2017, here in Jacksonville, Florida, at the University of North Florida. So come and join us in this conference.
Thank you very much for your support and
You're
the
welcome.
foundation, and also for mentioning the symposium. If anyone is interested in attending that event, there is a link available on the Judi Nicholson Foundation website. So you can find it on our Facebook page, or you can also find it at jnfkidneycancer.com. We did have another question come in on the feed just now, or do you have do you have a few more minutes?
Sure.
The Cowser says, the promise of immunotherapy, is it something that one can expect in the near future as a strong and viable option regarding treatment?
Immunotherapy is already an option for kidney cancer today. And I think what will be the next step will be combining immunotherapy, studying the toxicity, and how to maximize immunotherapy. And hopefully we can cure certain subsets of patients with kidney cancer. And the potential of using markers to identify those patients who can potentially respond to immunotherapy. So in the big picture, not every single patient would respond to immunotherapy. However, there are subsets. We have to realize that there are toxicities to immunotherapy, so we have to be cognizant about that and give the select patients who would benefit from it.
Thank you very much for your
You're
questions. And lastly, if he has additional questions on immunotherapy, should he see an oncologist in his area, or is there someone else that would be better to talk to?
Absolutely. The oncologist would be the best person, and it is only indicated for metastatic disease at this time. So he has to see a medical oncologist.
All right. Well, thank you so much for your time. We hope we can do this again soon. And let me switch the camera. Thanks everybody for your questions today. We look forward to the next one coming up in a few weeks. So please like our Facebook page. You can keep in the know about the different treatments that are coming around and the next patient support series that we have coming up. March is Kidney Cancer Awareness Month, so we would love for you to share this with your friends and family. If you do have any additional questions, you can still leave them in the comments. We'll get back to you. We look forward to supporting you and your loved ones through kidney cancer. If you're a patient or if you are a survivor, we've got your back. So thank you very much for your time, and everyone have a great day.